Good morning, everybody. So in our ongoing venture of introducing academic Sundays in IMA NDB branch, we have started the series on oncology. We've had one on colonic cancers and one lecture on CA breast. Continuing the series, we are today exploring something which often flies under the radar, but is a pretty important area of our life, and I think should get a little more attention. So we are having today a session on malignancies around the eye, and we have with us Dr. Sima Das and Dr. Saurbhi to have this session go forward with Dr. Sanjay. Sima is the head of Oculoplasty at Shroff Charity Eye Hospital, and has been, so I know her personally also. Her dedication to, though she has sent me her bio, which I'll read later, but her dedication to particularly the retinoblastoma babies is something that is unmatched. I think not many people will see that kind of both dedication and perseverance, because it's not a very happy thing to see babies suffering so much. She completed her basic medical education from Lady Hardinge Medical College and did her postgraduate training from from Maulana Azad. She then did a clinical fellowship in oculoplasty from LV Prasad, and is now in charge of both oculoplasty and medical education department at our hospital, the Shroff Charity Eye Hospital at Daryaganj. So it has been a gradually growing interest, I think, that has caught on the momentum and has taken over her life. So we see her enter the OT at 8 a.m. and we don't know when she's going to leave. Some days 8 p.m., some days later, a few days, maybe a little earlier. Seema, our coffee is still pending.
Yes, someday.
No, soon. Someday soon.
Someday soon.
Yeah. And Saurbhi, though I don't know you personally, but so Saurbhi also is in this niche area of oculoplasty, and she's highly skilled and internationally trained with several years of experience. She did her MBBS from Maulana Azad. So both of you are Delhi-based oculoplasty surgeons. And she finished her post-graduation in ophthalmology from RP Center in 2009. She has several awards and was even the best senior resident in ophthalmology in 2012. Following her senior residency, she did oculoplasty and ocular aesthetics fellowship at Leicester University at UK. She started her practice as a cataract refractive and oculoplasty surgeon and is now practicing exclusively in the area of periocular plastic and reconstructive surgery. She has several papers to her credit, and it is a huge privilege to have both of you deal with this often ignored area of ophthalmology, especially as it relates to general physicians and increased and early detection through a good, robust referral practice. It would be good to have Dr. Sanjay take over now. I don't think he requires too much of an introduction, but he's so he's also a Delhiite, Maulana Azad, Lady Hardinge, GNEC alumnus, and gold medalist in his MS. I am a little biased when I say this, perhaps, but I have seen from my internship days, his surgical hand, and one of the reasons why I think I fell for this guy. He's an excellent surgeon with exceedingly good outcomes in anything that he has touched. Oculoplasty was one of his passions, which I think took a backseat to cataract and refractive surgery, depending on the need of the day. At that time, blindness was much in focus, but it is one of his passions which brings him back again and again to this specialty. Over to you, Dr. Sanjay.
Thank you very much for clarifying that our relationship is purely clinical, that it is surgery that you fell for, not for me, So great, and well, yes, oculoplasty has been my passion, and I really love it. I used to practice oculoplasty till about 2005, and that's when we started Max Eye Care, and I chose to give up that practicing that and stick to only cataract and refractive surgery, because I was not formally trained to do oculoplasty. I could not call myself a legitimate oculoplasty guy. That's why I never said that. But I feel good meeting people who do oculoplasty. I always encourage them. I always promote them, and I kind of refer cases to them, and I stay in touch with them. That's the reason why we have Sima Das and Saurbhi Khurana over here. Both of them are excellent oculoplasty surgeons. I don't know Sima personally, but I know Saurbhi personally. She has done a tremendous amount of work for Max Gurgaon during the second wave of COVID, when we were hit by those the black fungus or ROCM, and she really helped us a lot. So I'm glad that today we have both of them. And today Sima will be talking about a topic which is, as Nidhi said, is very, very important but often ignored. And I'd rather that she should touch on the tumors as such of the eye and the orbit, and not just the cancers or malignancies only. So without wasting time, we move on. So Sima, thank you very much for joining us and welcome here. And please start with your talk.
Thank you very much, Dr. Dhawan, Dr. Nidhi.
I think before starting, let Dr. Vivek Kumar say a few words.
Oh yes, I think that's in perfect order. Sima, sorry for this interruption, but I think since Dr. Viveka has to, he's on the road right now, he may have to disconnect. So I would request him to say a few words. He's the president of our branch. Dr. Viveka, are you there? I think he got disconnected already, which is what we feared.
Okay.
Yeah, Sima, please go ahead.
Thank you very much, Dr. Dhawan, and thank you very much, Dr. Nidhi, for this opportunity. And as you mentioned, the tumors are something which maybe forms a very small kind of tiny mini proportion of, if you compare it with the other tumors and the cancers. So that's probably why it's not talked about much in the general cancer forums per se. But of course, these are the things which many of us, not only ophthalmologists, but even other physicians, specialties can pick up. And there is a lot of overlap when it comes to the presentation as well as the management. So it's not really in the top 10 common cancers. I mean, I was trying to get some data, and the ICMR data, the last published one in 2020, it says India probably has near about 13 lakhs new cases of cancers which are diagnosed in that particular year. And the projection, of course, is on the rise. And the eye cancers were just about 1,500 to 2,000. So it's a very tiny proportion, less than 5% possibly. And that is the reason we don't get to see them very often, especially in general practice. And that's the reason why maybe there is a little lack of awareness about the various presentations of these tumors. And this is also the reason why maybe we tend to miss the diagnosis sometimes, and also we tend to misdiagnose them as something else other than tumors. And this might cause a delay in the initiation of the treatment. Now, the good part about the eye is, the eye, unlike other tumors or the other cancers of the body, the tumors of the eye are visible tumor. The eye is the structure which helps us see, and everything in the eye is also kind of, very transparent and visible, and it includes all the tumors, be it a benign or a malignant tumor. So anything in the eyelid, it's very easily visible. We don't need any specialized investigation or equipment to see them, to diagnose them most of the time. Anything in the conjunctiva is very easily visible by a routine, even by a torchlight evaluation. And the best part is even the inner part of the eye is visible, unlike something inside the tummy or the abdomen where we can't see the pancreas. So anything which happens in the pancreas tends to get diagnosed only when the symptom starts. But here, even a simple evaluation can kind of, make us see even the retina of the eye. So anything inside the tumor, inside the eye, any tumor developing there is also easily visible. And this is one of the retinoblastoma tumor, which is developing in the retina of the eye. So that's the reason it's easier to diagnose them, and it's possible to diagnose them early if we are aware of how they look like. And my talk today is going to be very general, just to focus on the various presentation of some of the common tumors that not only ophthalmologists might see, but even any other specialty physicians or even a general physician might encounter. So talking about cancers, ocular cancers, I mean, if things are so obvious, there is no issue with the diagnosis. We know that the first one is a basal cell carcinoma, which more often than not, the head and neck surgeons will possibly be managing this kind of at this stage of the tumor. Maybe in the initial stages, a dermatologist might be the one who might see those lesions. This one was a sebaceous gland carcinoma. Again, at this stage, probably not only ophthalmologist, we need to have the oncologist, radiation oncologist, medical oncologist on board to kind of manage those tumors. But not all of them are going to present, and we really don't want them to progress to this stage, and we want to pick them up at a stage where things are not very obvious. So a small lump and bump like this, which can misdiagnosed or maybe ignored as a small infective or an inflammatory lesion, something known as lesion of the eyelid, is again actually a malignant tumor. This was a very early stage of sebaceous gland carcinoma. So is this a very early stage of this was actually a conjunctival amyloidosis, but can easily be misdiagnosed as a small subconjunctival hemorrhage or a conjunctivitis. And same as this lesion on the cornea, which can easily be misdiagnosed as a corneal opacity, especially in an elderly kind of person where corneal degenerations and other age-related changes tend to happen. So these are the stages where we need to pick them up. And if you're able to pick them up at these stages, the prognosis is excellent for tumors. So talking about some of the common eyelid tumors, these small lumps and bumps like these are the ones what we commonly see, maybe in our family, around us, even in patients who come for other problems, not on the eye problems. Sometimes they have those kind of lesions, a small nevus, a small lesion. These are all benign lesions. And essentially, if the patient wants treatment, mainly it's for the cosmetic purpose that we need to treat them. But even small bumps and lumps, which are kind of, can start off very small, but has, different colors, like this was a very early basal cell carcinoma, a black tumor, early sort of, surface, but there is ulceration of the surface and it has been there for a long time. So initially you might think that it could be just a small nevus of the eyelid and tend to ignore it. But looking at the other signs, like an ulceration of the surface, the chronicity of the lesion, and the base, which is sort of, not, it's a very broad-based lesion, unlike an nevus or other things, which might not be such a broad-based stuck-on appearance. Small nodule, but it's a very angry-looking nodule. You can see those blood vessels there. It's very vascular. So this does not look like a very normal infective pathology, especially it has been there for a long time. So those are the kind of lesions we need to be a little cautious about and not just dismiss them as non-serious conditions. And do get a referral with an ophthalmologist or specifically maybe an ocular oncologist to rule out something more serious. So the first one we know was a small basal cell carcinoma, the second one was actually not a very common tumor of the eyelid, a sweat gland carcinoma, but nevertheless a carcinoma, which has the potential to kind of grow and spread if not treated on time. Now, basal cell carcinoma, I just wanted to speak a little bit more about this because this is one of the very common misdiagnosed tumor of the eyelid. Now, this gentleman was initially referred because he gave a history of trauma following which he had this eyelid, which probably they thought had some trauma. It got lacerated, and nothing much was done at that time. And over a period of time, things did not improve, and it just kept on kind of, remained like that, angry looking and not a normal looking eyelid per se. But initial consultations, the diagnosis was post-traumatic eyelid deformity with loss of eyelashes and other things. But if you have a closer look, we can see probably this was the stage when he came to us, things were much more apparent. But in the initial stages, things might not be that apparent. These small dark areas of rolled in edges probably was not apparent that time. And it was just loss of the eyelid margin, which must have made somebody diagnose him as a post-traumatic eyelid deformity. Now, this was a basal cell carcinoma, again, one of the variant that we call as the sclerosing variant, because it has a lot of cicatricial changes. Dermatologists tend to see these kind of lesions much more common than we see probably in the eyelid. This does not have any definite nodule except for these small areas. It's a very diffuse area of fibrosis and can look like a post-traumatic sequelae. But looking at the rolled in edges, looking at the pigmentation, looking at the chronicity, looking at the progression, we need to be a little more suspicious and do need to go for a biopsy to confirm that it is not a basal cell carcinoma that we are dealing with. Because eventually we don't want them to progress to this stage. At this stage, there is not much, both in terms of surgical intervention, radiotherapy, chemotherapy does not work in basal cell carcinomas. So we really don't have much to add at this stage. Hence, we don't want them to progress at that stage. If it can be tackled at the stage when it is still localized to the periocular area, then a good surgical kind of, removal with margin clearance gives a very good prognosis. For advanced stages, we now have a medical management. This medicine is used not very frequently by ophthalmologists, but of course the oncologists use it. It's a Hedgehog signal pathway inhibitor, and it has been found effective in advanced stages of basal cell carcinoma. But in our settings, cost is the issue, which is a big hindrance in kind of, letting our patient use it. It's a daily medication. It's an oral tablet, but monthly cost goes somewhere in the range of 1.5 to 2 lakhs, which most of these patients can't really afford because the treatment has to be given for a long time. So better not to let it progress at this stage. Now, these are another small, simple things we must have seen in elderly kind of, our relations, family, friends around, that we tend to develop these small skin tags in our eyelid with age. And these are basically the hyperactive or the over proliferation of the epithelium where the keratin tends to get collected. And this form these small skin tags. Mostly a concern, cosmetic concern, but sometimes they can be itchy, and that's the time when patient usually goes to the dermatologist for removal of those tags or cauterization. But generally, the dermatologists don't really touch the eyelid area because that's a very sensitive area, both for using cautery or other invasive modalities. But what we need to be aware of that not all cutaneous horns that we call them, collection of the dead keratin, are sort of benign. They are not simple skin tags, but even a early squamous cell carcinoma of the skin of the eyelid can begin like a cutaneous horn. Like we can see the horn here, it's keratin deposition, but the pathology is somewhere in the base of the lesion here. It was a squamous cell carcinoma, which was kind of, because the cells are proliferating, they are shedding in more keratin, and that's what is getting deposited. So if you just look at the superficial part, we might miss the diagnosis, which is lying kind of, it's like the tip of the iceberg, which is visible. So if we just kind of, excise the superficial part, again, the diagnosis is going to be missed and the lesion is going to still remain and it will grow in size. So in this kind of lesion, it's important that we look at the base of the lesion and make sure that it's not a squamous cell carcinoma that we are dealing with. And if we are doing a biopsy, the base has to be biopsied and we should send it for histopathology evaluation. Now, things like this can look very ominous and very kind of, aggressive looking, almost like a malignant looking thing, but this was a young girl and she has this lesion since birth. So this is what we call it as a split nevus of the eyelid or a kissing nevus, that what is commonly called, where the nevus is involving both the upper and the lower eyelid. And in terms of reconstruction, because these are mainly cosmetic concern, they are not malignant lesion, and the potential for malignant transformation is not very common, though it can happen, but mostly the cosmesis is the concern. So difficult to reconstruct lesions, but again, we need to especially if the lesion is like this, where there is a lot of hypertrophy of the conjunctiva, probably because of the exposure. The eye doesn't close well here. So we need to rule out a malignant transformation with a biopsy. And once that is taken care of, we can take care of this kind of lesion. Once the plastic surgeon is taken care of rest of the lesion, the eyelid part can be taken care, and we can achieve a decent cosmetic appearance here. And with some amount of camouflage, like use of kind of, mascara and eyeliners, the rest of the things can be camouflaged. Another pigmented lesion, which again, the skin specialist, the dermatologist might encounter more frequently than us. And usually skin lasers are done for this kind of lesions, what we call is oculodermal melanocytosis, or the nevus of Ota. And what's important here is that we need to know that nevus of Ota might look like a very benign thing, mostly a cosmetic concern. But it's important that if the dermatologist is seeing those patients, we must send those patients for an ophthalmic evaluation also, because the risk of uveal melanoma developing in a patient of nevus of Ota is pretty high. It's 1 in 400, which is not a small figure. And if the lesion is extending to the scalp area like this in front of the hairline, sometimes this pigmentation can also be there in the meninges corresponding to meningeal melanoma over a period of time. So just taking care of the skin is not enough here. A ocular consultation, as well as if there are signs and symptoms, then probably an imaging of the brain to rule out any meningeal involvement is also advocated and required here. Like this young gentleman came for this periocular pigmentation. He has some pigmentation of the sclera here. And when we saw his eye, he had an uveal melanoma. He's a young patient. You can see here, he's in his 30s, which is not the age group when a melanoma develops in the eye. But he did have a melanoma because he had a risk, which was oculodermal melanocytosis. Now, this is a typical uveal melanoma, which an ophthalmologist can easily diagnose. And melanoma is the most common intraocular tumor in the eye. So that's the reason this patient needs to have an yearly ocular evaluation, which includes the fundus evaluation. So a little bit about melanoma, since we are talking about melanoma. It's the most common intraocular tumor in the adults. And most of the studies say that whether you enucleate the eye or don't enucleate, especially for bigger tumors, it doesn't make too much of difference in the survival of the patient. But in smaller tumors, if you're able to pick them up early, we can prevent a metastasis. So the melanoma, the problem is not recurrence in the eye after treatment. The problem is the systemic metastasis. So the more earlier we are able to pick it up, the more easier is the treatment. We will be able to save the eye. And though enucleation or the eye removal remains the conventional treatment modality, use of other modalities like, a very localized radiation to the eye, what we call it as brachytherapy to the eye, can take care of the melanoma if it is at a very early stage. So this was actually not for a melanoma patient, but this was for a retinoblastoma patient. But the technique of brachytherapy remains the same. So what we do here, we expose the sclera of the eye corresponding to the quadrant where the tumor is inside the eye. And this, we put a radioactive plaque. This inner surface of the plaque has it's a radioactive surface. And it's ruthenium, which is the element which emits those beta rays, which goes into the tumor. And eventually it kind of, stops the growth of the tumor. So once we sort of confirm that, we are at the correct position, it has been put at the correct position, we initially localize it using a dummy kind of plug, which does not have radiation. We don't want everybody, including the staff, the medical team, to be exposed to the radiation by using the active plug till the the last moment. So once the positioning, everything has been sort of taken care of, we place the sutures, which is going to anchor the plaque for some period of time. So typically in melanoma, 5 to 6 days, or sometimes even more than a week time is required to treat these lesions, depending on the size of the tumor. So that's when the radioactive plaque is taken out. It is put in place, and the pre-placed sutures are then used to anchor it, and it remains in the eye for the required duration of time. And when the treatment is over, we take it out. It's a simple treatment modality, but it can take care of small uveal melanomas. Like in this tumor, we see that over a period of time, 6 to 8 months down the line, the tumors start shrinking, and eventually this tumor has almost become a flat scar over a period of time. Of course, this patient needs periodic follow-up because there are chances of systemic metastasis to develop. Other pigmented lesions around the eye. Now, this patient does not need any diagnosis. Looking at the patient, we know that this is a xeroderma pigmentosum patient, and it's not only the eye which gets affected here, but every part of the body possibly can get affected. And most of the time, the cause of the mortality, early mortality in this patient is one of the other cancers which this patient tend to develop. But since face is the most exposed part of the body, the sun-exposed surface, and it's very difficult to cover the face. We can cover other body parts, but face is something we really can't cover much. So that's actually bears the brunt of the sun exposure and the consequent development of the tumor in this patient. Like this tumor, we can see there was a small basal cell carcinoma in the eyelid here. But what can also develop in this patient, like we see this fleshy pink-looking lesion in the eye here, right at the center of the eye, is a squamous cell carcinoma. So this patient has almost 1,000-fold increased risk of malignancies develop, and this squamous cell carcinomas tend to be much more aggressive than the other non-syndromic squamous cell carcinomas, which we tend to see in the eye. So that's the reason sun protection, ocular evaluation to detect the tumor at an early stage is very, very important for this patient. And if we can to see a patient of xeroderma, it's a must that this patient should get a periodic ocular evaluation and to look for any tumor developing in the eye, which is pretty frequent in this patient. So other than xeroderma, there are other systemic, like if you're seeing HIV/AIDS patient, they also tend to develop a lot of ocular surface squamous cell carcinoma. Any immunosuppression for organ transplantation, for kidney transplant or post-heart transplant, these are the patients, again, who are more at risk of develop ocular surface squamous cell carcinomas and few other syndromic association other than xeroderma. So these are the high-risk patients which needs to be evaluated periodically. While saying that, the squamous cell carcinoma, which we otherwise see in elderly patients, which is again one of the pretty common tumors which an ophthalmologist tend to see, can actually develop as something like this. Now, this is a very interesting story. This gentleman was seen by an ophthalmologist, and he came because of this irritation, watering from the eye, a little bit of blurring, which he felt there was something in his cornea which was causing this problem. And he underwent an evaluation where there was a little bit of haziness of the cornea which was detected. And when we saw, this was the picture, and the diagnosis was that probably while checking the pressure of the eye, like when we tend to check the pressure of the eye, we use a device called applanation, which touches the cornea. It's a round circular sort of disc surface. And many a time, if the person, the optometrist who is doing the evaluation is not very careful and uses a little pressure, it tends to cause a abrasion of the epithelium of the cornea. So that's what it was thought, that he probably has some kind of problem, recurrent corneal abrasion, and which probably might have got aggravated post-applanation. And he was prescribed some symptomatic treatment, but since it was there for some kind of, not really resolving even with the treatment, that's when we got a little suspicious. And when we stained with fluorescein, we can see there is some epithelial defect. The green color is the bare epithelium, which tends to get stained with this special dye, which ophthalmologists very frequently use in the clinics. But there were also this extension, almost like finger-like sort of extension from this main area, called something known as a fimbriated surface. So that's when the suspicion of an early squamous cell carcinoma was arose, and we did a simple test of corneal scraping. It can be easily diagnosed on cytology, on GIMSA stain. So we just scrape up the epithelium of the cornea, seen under microscope under GIMSA with GIMSA stain, and that's when you can pick up the malignant cells, the atypical cells. So diagnosis is confirmed, and as ophthalmologists very fond of, treat everything with eye drops. For ocular surface squamous cell carcinoma now, the standard treatment modality is not really systemic treatment, not surgery, but topical, either chemotherapy with mitomycin C or 5-fluorouracil eye drops, or topical immunotherapy with interferon. And the response rate is pretty good. In this gentleman, we use interferon, and we can see the cornea clearing up after a couple of months of treatment. And the good thing is, if you're able to pick it up at this stage, there is usually no morbidity which is left behind, and a complete cure is possible. Sometimes the squamous cell carcinoma can be a little more advanced at presentation. Here in this patient, we used a combination of topical chemotherapy and also a subconjunctival local injection of chemotherapy, interferon immunotherapy. So, and these are the appearance at follow-up, almost a complete regression. But since this was a more extensive lesion, this patient needs to be on a periodic follow-up with the ophthalmologist. So a chronic red eye which does not respond to routine treatment should, especially in an elderly gentleman, should always go for further evaluation to rule out any squamous cell carcinoma which might be developing, and they can be of different color, different size, different shape. I mean, there is no set pattern. Some can be brown, very rarely black. But what is unifying feature in most squamous cell carcinoma is the presence of keratin, the white keratin which develops on the surface. Even if there is a speck of keratin, it should make one suspicious and should go for further evaluation. So the point here is that any nodule on the conjunctiva, that is the white part of the eye, it needs further evaluation. It could be something malignant, especially if we are seeing it in an elderly gentleman developing for the first time in life, and especially if it is only in one eye. So squamous cell carcinoma otherwise are sort of, not really, they're locally invasive tumor, but the metastatic potential is not very high. So that's a good thing, but they can invade inside the eye. And if we let the tumor progress like this, the patient might eventually lose the eye. So it might be difficult to take out this tumor and save the eye. And sometimes enucleation has to be done for this tumor. But now with the use of plaque brachytherapy, we can even save some of the tumors which has progressed a little bit. Like this tumor had already gone into the sclera, but luckily it has not gone inside the eye. So we could take out part of the tumor, and whatever was left behind, which was gone inside the sclera, that we could treat with the radiation. And over a period of follow-up, it's almost a year follow-up now, and this patient is free of recurrence as of now. So the last bit in the eyelid tumor, this is again something very common, chronic infection of the eyelid. Maybe we must have seen it in some of our patient, non-ophthalmic patient also. We call it as a chronic meibomitis, inflammation of the meibomian glands. So needs a lot of symptomatic treatment in the form of antibiotics, steroids sometimes, and other things, topical antibiotic and steroid. But some of the variant of sebaceous gland carcinoma, the pegytoid variant, what we call, can actually present like a chronic inflammation of the meibomian glands. The eyelid has a lot of meibomian glands, and the sebaceous gland carcinoma is a tumor from the meibomian glands. So sometimes it can present without any visible nodularity on the surface, but it can be just a diffuse thickening. So especially we can see it's absolutely unilateral. The other eye is absolutely fine, which is a very unusual finding in an infective pathology, like an infective or an inflammatory meibomian gland inflammation should be usually bilateral, especially if the patient is elderly like this. Now this definitely needs further evaluation with a biopsy to rule out a pegytoid variant, which is one of the more aggressive variant of sebaceous gland carcinoma. Talking of conjunctiva, I'm sure this everybody will be able to diagnose this. This is a subconjunctival hemorrhage, which is again something not uncommon. It can happen post-viral infection also. It can happen post-trauma also. We tend to see a spontaneous subconjunctival hemorrhage in hypertensive patients also. So most often than not, they will be kind of, something not serious, benign thing, just a small hemorrhage, which tends to resolve over a period of a couple of weeks. But if the hemorrhage keeps on coming back, especially in the same location, and keeps on coming back repeatedly, now this patient definitely needs a little better evaluation. Now this lady had, when we saw her after the hemorrhage subsided, then we could see that there was something in the conjunctiva, some thickening of the conjunctiva here, and on little high magnification, we can see that there is a very diffusely thickened conjunctival lesion here, and the surface looks little what we call as waxy. It's almost like the surface of a candle wax. So this is the typical appearance of a conjunctival amyloidosis. And this lady, if you see, has it in both the eyes. So this was a bilateral conjunctival amyloidosis, which can have systemic association, can be associated with systemic amyloidosis, sometimes with other disorders of the multiple myeloma spectrum. So a subconjunctival hemorrhage, if it does not resolve or it keeps on coming back repeatedly at the same time, we possibly need a little more detailed evaluation looking at that particular site of the conjunctiva to rule out any conjunctival amyloidosis. So this is something which needs surgical treatment. We don't have good medical management for this. Drooping of the eyelid or ptosis is again something which is not uncommon, especially in the senile age group, and we do see it in the pediatric age group also, where the etiology is mostly congenital. But if the drooping of the eyelid has come for the first time in an senile age patient, it's not always that it's a senile ptosis. It's not a ptosis, is something what we call as drooping of the eyelid, and it tends to happen in with age where the eye muscles and everything becomes a little weaker. But if it happens for the first time, especially if it's like a little acute onset, like this lady had a little acute onset ptosis, and on imaging we can see that there is something inside the superior rectus and the levator muscle, the muscle which lifts up the eyelid. She also has some brain lesion here. It's almost a cystic looking lesion, and initially she was diagnosed as a cysticercosis because of the appearance, but since it did not resolve with the symptomatic treatment for cysticercosis, that's when the biopsy was done, it was diagnosed as a CA breast, and eventually she had a CA breast which was metastatic and presented with an ocular metastasis. So another gentleman, again, ptosis could be the presentation of any systemic tumor, especially if it is an elderly patient. Now here again, ptosis as the initial presentation, diagnosed as an initial senile ptosis. Somebody thought that there could be some redundancy of the conjunctiva here. The term which we used for that is conjunctivochalesis. He also underwent a excision of the conjunctiva, thinking that his ptosis or other ocular surface irritation could be because of that. But since his symptom did not resolve, a little detailed evaluation did show a mass lesion in the beneath the eyelid, which was hidden behind the eyelid. Now we took a biopsy from this mass, and on imaging we can see it a little better here in the superior part of the orbit. And this is what the biopsy revealed. He eventually was diagnosed as an NHL, a diffuse large cell variant, and on systemic evaluation, he had a systemic lymphoma also. So the systemic malignancy sometimes can manifest as metastasis to the extraocular muscles, to the orbit and the other structures. Sometimes we tend to see intraocular metastasis into the retina, and that's when the tumor tends to get diagnosed initially. So anything which is unusual, not fitting into the conventional pattern, especially if it's a little acute onset in an elderly patient, we must go for a little detailed evaluation, especially if there is a little bit of prominence of the eye also. So lymphomas are again one of the more common ocular tumors. It can be associated with systemic lymphoma. It can be just a standalone ocular lymphoma also. And this is how we usually see them. The typical salmon colored, the flesh of the salmon fish. This is how it usually looks like. And it's almost, the appearance is almost diagnostic, but biopsy is required to confirm the subtype of the lymphoma and to do a systemic evaluation also. And we need to know that these are the patient, lymphomas are more common again in immunocompromised patients, patients who have chronic inflammation, and also patients who have autoimmune disorders. So these are the patients where if there is anything which suspect that some redness is developing in the eye, which is sort of persisting, we should get a systemic, we should get an ocular evaluation. And the good part is that most of the subtypes of lymphoma that we see in the eye are the MALT NHL subtype, which are kind of good prognosis subtypes. Saying this, some of the lymphomas can be a little more aggressive. And again, this patient might be seen by anybody else, maybe not an ophthalmologist, because she had an acute onset red eye, which was thought as an orbital cellulitis. And the patient might go initially to the physician, might go to maybe a sort of dermatologist also sometimes, or whoever is the nearby doctor. And this, again, she was treated with antibiotics. She also received steroid, but somehow the inflammation did not subside. And that's when the suspicion arose. And when we saw her, we got the imaging done, and this was also diagnosed as a lymphoma, which was involving the lacrimal gland and the eyelid. And this was the reason why there was a chronic inflammation. So this was a little aggressive subtype. This was not the B cell lymphoma. This was like a T cell lymphoma, which is a little more aggressive and can present with acute signs of inflammation. And many a time they can get misdiagnosed as an orbital cellulitis. So the point here is that any cellulitis, any infection, inflammation, which is not responding to antibiotics, maybe not even responding to steroids, we must get a little better evaluation and should go for a biopsy after an imaging. And steroid is something which can sometimes mask the initial signs of lymphoma for some time, but eventually, if it's lymphoma, is going to come back. So unless and until we are pretty sure that it is an inflammation only and it's not a malignancy, it's better to withhold the steroid, get an evaluation done, and then only start the steroid so that we can don't get a misdiagnosis. Now, this was the appearance after the chemotherapy was started. I think this was after 6 cycles of chemo, and then she currently is in remission and as of now doing well. Moving on to the pediatric age group, I'm not sure if there are any pediatrician in this group today. So in pediatric age group also, we tend to see the lymphomas and the lymphoproliferative tumors, and the spectrum here is an overlap between lymphoma and leukemia. Now, this child was thought of having a conjunctivitis, allergic conjunctivitis, which is pretty common in this age group because the eye was red, watery, itchy. But what was striking was the pathology was unilateral, which is not going to be the case in a patient with allergic conjunctivitis. Now, and this was much more fleshy appearing, unlike a conjunctivitis, which will be more flat. Now, this on biopsy, we did a biopsy because this was not really typical conjunctivitis. It turned out to be a lymphoblastic leukemia, ALL. And we did not suspect it initially to be an ALL because the presentation was so atypical. But for many children, like, if the dictum here we follow is that anything which is rapidly progressing, any proptosis, any redness, any swelling, any eyelid edema in a child, which is very, very rapidly progressing over a period of days or sometimes hours maybe, the first test that we do is a peripheral smear to rule out a leukemia. We really don't have to go for more invasive biopsy or any other thing. And many a times a peripheral smear is just sufficient to give us the diagnosis if you're able to find the blast cells and the OR rods and the other findings of the spear. Now, ophthalmologists can also pick up a very early leukemia by the fundus appearance. We know this rod spots, which are the white-centered hemorrhages, which develop in patients with leukemia and which can be easily picked up on ophthalmoscopic evaluation. Now, this one is for the ENT. In fact, Dr. Nishi helped in management of this patient. Now, this was a child which again had a very atypical presentation, came with this proptosis. We thought imaging showed a sino-orbital mass. We thought it could be like, we are talking about fungus these days a lot, rhino-orbital cerebral necromycosis. And children we know can have fungal infections. So this remains one of the differential here. Other differential, of course, remains any other malignancies involving the sinus and the orbit. But looking at the findings, infective pathology goes more in favor of infective pathology. This was also a chronic presentation over a period of few months. But our biopsy somehow did not reveal any fungal elements, no infection, even no tumor. So we were a little baffled. But what happened over a period of time, a couple of weeks after the biopsy, we just took an incision biopsy from the orbit. Sorry, a very tiny bit. But after a period of couple of weeks, she came back to the clinic and her proptosis is reduced drastically, which was very, very surprising because we really didn't do anything to take out the whole mass. And when we repeated the imaging, we can see that almost the orbital part is almost gone. The sinus part is much better. There is still some residual sinus mucosal thickening here. So we were at fix, like, what are we dealing with? But since it was kind of, status quo and it was a child and the suspicion for it being something unusual was pretty high, we decided to go ahead with a repeat biopsy. Now, this time Dr. Nishu went in, she took a biopsy from a little deeper part from the posterior wall of the maxillary sinus. And that's when we picked up the atypical cells. So eventually she was diagnosed as an acute leukemia. And this time when we did the peripheral smear for her, we could see the blast cells in the peripheral smear. Now, possibly when we give the child an anesthesia, steroid is always given. So I just put up this case to emphasize the fact that, steroid can sometimes give us a very false sense of security that, we have cured the disease. So probably just with 1 or 2 shots of steroid, the leukemia just melted away. But of course, it is not the treatment. It's just a matter of time when it is going to come back. And that's what has happened in the post-operative period. And if we had not gone ahead with a repeat biopsy, we probably would have missed the diagnosis in this patient. So this also was an acute leukemia. Another patient was lacrimal gland swelling, eventually turned out to be an acute myeloid leukemia. Now, a little bit about the neurogenic tumors. Gliomas, we know, are associated with the neurofibromatosis type 1. And these are the patients which can be seen by the neurosurgeons, maybe sometimes the dermatologist. But what we need to know is that NF can be associated with the optic nerve gliomas, which can be bilateral sometimes. Like this patient had a unilateral massive involvement in one eye, but the other eye also had a slight disc pallor. So for glioma now, what we follow is smaller children. If it is affecting the vision, it's a benign tumor, it's not malignant. We treat it only if it is affecting the vision. So that's where the role of ophthalmologists come into picture. Periodic vision evaluation, including visual field and as well as imaging, is very important. If there are any signs of progression in terms of growth of the tumor as well as involvement of the visual field or the vision, that's when we need to start the treatment. So small children, chemotherapy works pretty well. In older children, radiation is a treatment option. But in children like this, where the vision is already gone, it's a disfigured eye, proptotic disfigured eye, there is no vision. Sometimes we can do a debulking of the tumor also, take out the optic nerve to kind of, give a little better cosmesis to the child. These are the plexiform neurofibroma, again, a very common association of NF1. Again, here the treatment has to be combined with maybe a maxillofacial or a facial surgeon. From the ophthalmic point of view, what we can do is something known as template debulking, where we just take out the template of the normal eyelid, leave behind part of that, and take out everything else which is there in the eyelid. These are long surgeries, need staged correction. This patient initially had an eyelid debulking, followed by a mid-phase debulking, and after that followed by a ptosis surgery. So some acceptable sort of cosmetic appearance can be achieved, but we know that these tumors can keep on coming back over a period of time. Again, hemangiomas is something which pediatricians tend to see very often, and they are need to be involved in the management of hemangiomas, because now the treatment of hemangioma, the first line, unlike we used to use steroid earlier, now it's oral propranolol, and especially for big ones like this, and they tend to respond pretty well. Like in this child, after a year or so, it's almost gone, but we need to know that again, the treatment is not over with the resolution of the lesion. The child must be amblyopic because the tumor has been there like this for a long period of time. So the child needs to be seen by a pediatric ophthalmologist, need to have periodic vision checkup, as well as treatment of the amblyopia with patching and other treatment, whatever is required. So again, ophthalmologists are very fond of using their tricks and tips. Like this is the fibrin glue, the cyanoacrylate glue, which is used by the cornea people here for their, sealing those small perforation of the cornea. And we tend to use this for the small hemangiomas or the vascular tumors to embolize these lesions before we excise them. Otherwise, they are very vascular lesions that tend to bleed a lot. But if we inject the glue inside, it causes microembolization of the feeder blood vessels, makes the excision much more easier, and the surgical treatment much less messier. So last bit about retinoblastoma, as Dr. Nidhi mentioned, this is something which is very close to my heart. And but I want to keep it simple because there are a lot in retinoblastoma to speak, which might be beyond the kind of, the scope of this talk. But any white reflex in a child's eye, unless proven otherwise, is retinoblastoma. And if we are able to pick it up at this stage, we are making a difference of life and death for a child. So this is something which can be picked up right from pediatrician, physician, gynecologist. Anybody can pick up the white reflex. And just a little bit of kind of, guiding the family that, look, you need to go with the child, see an eye doctor, because this eye does not seem to have, something seems to be wrong. It could be something else. It could be a cataract. It could be some other pathology. But unless proven otherwise, any white reflex is retinoblastoma and needs an urgent evaluation. Saying that, it can present in many other ways, and which we really don't want to see, like the tumor coming out, the eye becoming thicical because of the massive orbital cellulitis, which can happen when the tumor sort of, undergoes necrosis. Sometimes, in fact, in our scenario, Indian scenario, more often than not, we see them presenting with metastasis, which is a very sad scenario to see. Now, enucleation or removal of the eye has been the standard treatment modality when the tumor is still inside the eye. But we now have many other modalities where even with a little advanced tumor, we are able to save the eye of the children and sometimes the vision also. This we are talking about when the tumor is still inside the eye. So we take help of our retinal colleagues to give an injection of chemotherapy inside the eye. This is known as intravitreal chemotherapy, which is a very specific technique and it has a very specific indication. It should be given only after a detailed evaluation by an ophthalmic oncologist, and we are sure that, okay, this is the tumor which fits into the criteria, because every tumor is not a suitable candidate for intravitreal chemotherapy. So these are some of the tumors like, vitreces. These are the suitable tumors for intravitreal chemotherapy. Going from from the intraarterial chemotherapy, which is traditionally being used for hepatocellular carcinoma, we use the same principles to do an intraarterial chemotherapy for retinoblastoma also now. The conventional chemotherapy which is given is intravenous, where the concentration of the drug inside the eye is not very high, because eye we know has this, the blood retinal barrier is there. It's a very secluded area. So giving it via the arterial route causes it to kind of, go inside the eye at a much higher concentration. And this is now almost become the sort of, first line treatment modality for retinoblastoma when the tumor is inside the eye in most of the developed countries. But unfortunately here in our setting, the cost is a kind of, constrained, and we tend to use it for very selected group of patients where kind of, we don't have any other modalities, where intravenous chemo doesn't work, intravitreal doesn't work, and we still want to save the eye. So this is done by interventional neuroradiologists. So we need to tie up with the interventional radiology person, and it is done in the cath lab or the neurointerventional lab. And where, just like the way they go for cardiac catheterization or a neurocatheterization, they go inside, a microcatheter is put inside the ophthalmic artery ostium. So that's where the catheter goes in. And through that microcatheter, then the chemotherapy medication is delivered, and consequently, a very high concentration of the drug can go inside the eye. The results are pretty good. Like we can see this tumor, which was after intravitreal chemotherapy as well as intravenous chemotherapy, after one cycle, the tumor just shrinks because of the high concentration of the drug, which goes inside. Plaque is again used for retinoblastoma also very extensively. Like this was one patient. Again, it is not used as a first-line treatment modality, but it can be used as a modality where everything else has been done and it's kind of, there is still some residual active tumor. And this is after 4 to 5 months after plaque, where you see the tumor has become almost completely flat. So if we detect on time, 95% survival and eye salvage has been achieved for retinoblastoma, at least in the developed countries. But unfortunately, in our setting, we tend to see the patient in this stage presenting bilateral with metastases with no previous consult at all, which is very, very unfortunate, because, even though we have some treatment modality for this stage also, but of course the prognosis is pretty poor at this stage. So better is to prevent it, and a simple kind of red reflex screening is something which can pick up the tumor at an early stage. And it can be done not only by the medical professionals, but even a field worker, the community health worker can actually, when they go for screening of the child in the community, can screen the eye of the child for red reflex. So this is one of our community health worker who is using this special device called ArcLight, which is a mini ophthalmoscope sort of thing, who is trying to screen the eye of the child for a red reflex. And sometimes they can pick up those kind of, retinoblastoma. So this was one of the, in fact, the training sessions that we had. We keep on having those training sessions for our community health workers on how to do the red reflex testing, how to detect and kind of, white glow in a child's eye. So this was in one of our satellite centers where after one of the training session, one of the participants who was there, while doing the screening in a community, actually picked up this child who had a white reflex in the eye. Now he was sent to us in the base hospital at Delhi, and after examination, he was diagnosed as a retinoblastoma in both his eye. This one eye was advanced, that's why it was detected. The other eye had a very small tumor, which we could pick up on examination. So this child was started on treatment, and fortunately, he's still under treatment. We could save both his eyes. But what was important is that we knew that this child also had another younger sibling who was just about 1 or 2 months old. But we know that retinoblastoma can be hereditary, so we screened the other sibling also. Now this sibling was having a small tumor in one of the eye. Now only because we picked up this child, one health worker picked up this child, the other child could be picked up and the tumor could be detected at a stage which otherwise we hardly detect. This was a group A tumor, which is very, very rare to detect otherwise. So that's the beauty of screening. And I think screening should be incorporated in as part of pediatric eye screening programs. And some of the states are now trying to incorporate red reflex screening and with screening of other pediatric congenital anomalies as part of the NEEP project. What is also important in retinoblastoma is to do a targeted screening. So retinoblastoma, we know, is not a very common tumor. So if you try to go into the community and screen every child, it might not be practical to pick up RB just by screening. So we need to do a targeted screening, meaning that we need to know the children who are at high risk for developing retinoblastoma. So here, genetic testing plays a very important role. And this is one tumor probably where genetics is sort of, It's almost part of the diagnostic workup of the children, and we do it for every child of retinoblastoma that is treated here. Now, this small kid, 2-month-old kid was diagnosed as one-eye retinoblastoma, unilateral. Now, retinoblastoma we know can be unilateral, can be bilateral. When it's bilateral, it's always germline, means that there is a chance of another sibling developing the same tumor. There is a chance of the tumor being bilateral. Now, we detected a germline mutation in this child, and this eye was enucleated, but since we knew that the other eye can develop a tumor, we kept the child on a very frequent follow-up, and the follow-up here means an examination under anesthesia. And OPD evaluation is not enough to detect a retinal tumor in such a small child. Over a period of 3 months, we detected this small tumor which came up on the retina, and we could do a laser then and there and could treat the tumor then and there. So that's the idea behind a targeted screening, which should be targeted based on the genetic status of the children. And we can even go one step further, like for this family where the father had bilateral retinoblastoma when he was a child. His both eye has been enucleated. Now he came, this was the child whom we saw first. This was the index case, who again had both eye tumor. Unfortunately, one eye was already advanced. We could not save her left eye, but the right eye we could save with chemotherapy. Now, this child also had another sibling. And since we screened this sibling also as part of sibling screening for retinoblastoma, we detected a tumor in both the eyes of this child also. But since this was detected at an early stage, we could treat her with chemo and laser, and we could save both her eyes. Now, over a period of time, we counsel the family because this has a very high chance of any further pregnancy. There is a very high chance that the child is also going to develop the tumor. But since these are both girl child, the family was very keen on having a third pregnancy. And when the mother was pregnant, and we knew already the mutation which this child has, both the sibling has, the father has, we did a CVS, chorionic villus sampling for the mother at about 2 months of pregnancy. And we detected the same mutation in the child who was still intrauterine. We counseled the family for a termination of pregnancy, but they refused termination, thinking that it could be a male child this time. But we knew that this child is definitely going to develop the tumor, very, very high chance. So we kind of, did not wait for the term pregnancy, induced the labor at 37, let the child be delivered. And as soon as the child was delivered, the child was brought here for ocular examination. And here the tumor was there in both the eyes of the child. So from here, where the eye could not be saved, we could pick up a tumor at a very, very small stage, almost like a millimeter stage, where we can save the vision of the child, the eye of the child, and of course, further counseling of this family is required. Fortunately, this child was a male child, and hopefully they will sort of, not go for further pregnancy. So the last bit about rehabilitation, any cancer treatment is not complete without any rehabilitation, especially if you're talking about child. Eye removal surgery has to be done quite frequently in our settings at least. And it's not appropriate to fit a ready-made prosthesis for a child. We should give a customized prosthesis for a child, because we don't want the child to land up with infection, chronic infection, and then landing up with other problem of conjunctival scarring, and where the child is not able to wear a prosthesis later on. Visual rehabilitation is very, very important because it's not that every child will have vision. This child will unfortunately have to enucleate both his eyes by retinoblastoma. But we connected him to a school where he could go ahead with his classes using the braille, and some other children where they have the eye could be saved, but with low vision. We have a very good visual rehabilitation department who takes care of the rehabilitation part of it. So that's all about the tumor, and it's like it's not a single person job. We need almost everybody from each specialty: counselors, sisters, coordinators. Everybody plays a very important role when we talk about managing tumors of the eye. Thank you very much.
Thank you very much, Sima, for a wonderful and a very comprehensive talk. You kind of made everything appear so simple, and you covered everything. I think only one thing which remained was probably the dermatomyosarcoma. I think maybe Saurbhi can talk about that. So, Saurbhi, can I have your comments on the talk and anything special that you want to add to what has already been said by Sima?
So it was a very comprehensive talk, ma'am. Very nicely covered all the topics of ocular oncology. I think ma'am is fortunate enough to be working in a center where you have all the collaborative departments, and you can actually do, like, oncology was something that I was personally very fond of and into when I was doing my senior residency at RP Center. But now being essentially in private practice, some of the challenges that I think ophthalmologists who are practicing oncology face are, one, mostly, like you said, it needs the collaboration of oncologists, radiotherapists. You need a good radio diagnosis. So a lot of patients get amiss because cost becomes an issue. Going to all these multiple departments across the hospital becomes an issue. So those are some things that I face a problem with when I get extensive tumor cases referred to me. Another thing is also we need very good pathologists, because for a lot of early cases, I mean, I've had in the past 1 or 2 years early OSSNs or an early sebaceous cell carcinoma, wherein the diagnosis is a carcinoma in situ. And so you need a good, reliable pathology report to be able to pick up that, and that can sort of guide your management further in those cases, which is not like frank tumors. So that is, I think, so anybody who's practicing or looking at oncology sort of needs that collaboration, and a team to work with becomes very important. And a referral practice, because again, like a lot of these skin eyelid lesions usually go to the dermatologist. So I think more awareness amongst our colleagues and our non-ophthalmology colleagues about picking up these lesions early and referring it across to ophthalmologists becomes relevant. Even in multi-speciality hospitals, I sometimes feel like the oncology team is not really aware of an oculoplastic surgeon being there to deal with these reconstructive treatments. So a lot of times I see them being dealt with the plastic surgeons and the neurosurgeons when it comes to orbital tumors. So again, that awareness amongst the non-ophthalmologists that there is a specific specialty of oculoplasty that can actually deal with these periocular reconstructions and orbital tumor removals. I think those are the things that can be sort of stressed upon, and we can work our way towards that.
Yeah, you very rightly said, Saurbhi, that I find that ऊपर से neurosurgeon घुस रहा है आँख के अंदर, नीचे से ENT surgeon घुस रहा है आँख के अंदर, बाहर से plastic surgeon घुस रहा है आँख के अंदर. Everybody's trying to invade the orbit and take away our piece of work. But having said that, collaboration is the key thing. Starting from the time of the suspicion of a tumor being there, right up to the end of the treatment part, the collaboration is the key word. So I think everybody should be aware of the possibility of ocular and orbital tumors and malignancies, and they refer to an ophthalmologist, if possible to an oculoplasty surgeon, and then further things starts. And of course, the oculoplasty surgeon has to collaborate with the pathologist for making the diagnosis, an oncologist and an oncosurgeon, on radiation oncologist basically, to treat them completely. We at Max, we got a good oncology center, but I think we need to start cooperating with them in a better way. And so can you elaborate about, can you talk about rhabdomyosarcoma, Saurbhi? I think that's something which was missed by Sima.
Yeah,
just a few lines about that now.
No, actually, since you're mentioning rhabdomyosarcoma, recently I operated upon one of these cases. It was an international patient. So rhabdomyosarcoma, as we all know, is a tumor amongst children in the first decade. One of the most common tumors. It's fairly common in the rest of the body as well, but ocular rhabdomyosarcomas can present typically between children 5 to 12, 13 years of age. They present as a big, like a sarcoma, fleshy mass, which is picked up proptosis. And usually all it needs is mostly a biopsy and further treatment with chemo and radiotherapy. And most of these tumors do tend to resolve with treatment. So there was this kid who had been diagnosed with a rhabdomyosarcoma. I think the dictum for rhabdomyosarcoma elsewhere in the body is excision as far as possible, but that's not really the treatment modality for ocular rhabdomyosarcomas. So she was planned for an extensive exenteration and neurosurgical excision, and then that's when I was
I think we seem to have lost Saurbhi.
Yeah, I
She
think
got
we've lost her.
frozen. Yeah. So as she was saying that, the surgery is not the main line of treatment for rhabdomyosarcoma of the eye. It's mainly the chemotherapy which is more important. Am I correct, Sima? Can you add to that?
Yes. So rhabdomyosarcoma, we have very good chemotherapy treatment protocol. And in fact, surgery is only to diagnose the tumor. It's whenever we do a biopsy, we do an incision biopsy in rhabdomyosarcoma. Unless and until the tumor is sort of very well defined where we can debulk as much as possible, we really don't go for extensive surgery, because with the IRS protocol now, even the stage 4 tumor just melts away with chemotherapy. So surgery is not really the treatment modality unless and until you have done everything, all the chemo 12 cycle has been chemo, still there is some residual tumor. That's when we go in for debulking of the residual tumor.
So that brings me to a very interesting question, which is my favorite question, which I ask everybody, all the ophthalmologists. Why is it that left eye gets a very unfair share of things? Rhabdomyosarcoma is more common in the left eye. Nevus of aorta is more common in the left eye. Duane's retraction syndrome is more common in the left eye. Hemangiomas, orbital varices is more common in the left eye. Why is that so?
I think you are the best person.
you put the ball back in my court. Even Dipali is here. She's a squint expert here.
So the right is always right, Dr. Dhawan. So I guess so. But, interestingly, when I had delved into this, I'm not recollecting, but I'll come back with it because embryologically, there was something mentioned about the left side, why these conditions like Duane's and tumors are more common on the left side. We're not really being unfair to the left side, but it is so.
No, it is being unfair to the left side. And I had this discussion with Saurbhi also about the left-right difference. There's a significant difference. I don't know about the retinoblastoma, whether that's more common in the left or not, but many things are much more common in the left eye. And the only thing that I can think of,
Saurbhi has joined. Because of dominant right-sided.
The right being dominant is a different things more to do with the left brain, but the only difference that we could think of, and Saurbhi and I kind of concurred on that, was that the venous drainage on the right and the left is different. Especially if you look at the venous drainage in the cranium, how the sigmoid sinus drains to the right side and left side does not have that sort of thing. So the venous drainage is very different on the two sides. And possibly, the right internal carotid artery and the right ophthalmic artery branches out from the aorta first, followed later by the left side. So the even arterial difference is also there. So the difference in the circulation is the only thing we can think of in terms of anatomy and physiology, which could possibly be a factor in having the left eye get a very bad share. And so I cannot think of anything else.
I'll maybe go back to the retinoblastoma cases and check out, whether it's
just do that. In fact, the pictures which you showed were more common in the left side. I think more advanced in the left eye. That's what I noticed that there.
In fact, thank you for a nice presentation, lucid presentation. I would like to ask you that how common is these malignancies in common practice? Because as a physician, we see a lot of cataract cases, but hardly see any malignancy on a routine basis. And how common is it in people who are blind, especially from birth or later on?
Sir, unfortunately, we don't have a very good eye cancer registry as of now in India. Whatever registry is there is very patchy and regional. There is no pan-India registry, which probably is something which is very much required. But going by the data from the other countries who maintain a registry, the eye tumors probably, if we consider all cancers, is probably less than 3% or so among the whole malignancies of the body. So the possibility of a general physician or a non-ophthalmic kind of, medical practitioner encountering these problems probably is pretty low, because if there is an isolated problem in the eye, the possibility is that the patient will first come to an ophthalmologist. The areas where it might be more common.
But the clearance has to come from the physician for any surgery undertaken.
Yes. So if I see the general population, one is of course the ophthalmic surgeries, as you mentioned, cataract and all are pretty common. Most of the time they don't even go to the physician for a clearance because the surgeries usually are done under sometimes even topical anesthesia or a local anesthesia. Unless and until the patient has some comorbidity, probably even a physician will not even see the patient. The clearance is just given for a surgery under topical anesthesia. That would be one. Second area, I think the tumors which is syndromic association or a systemic association, those are the cases where the non-ophthalmic physicians can kind of, at least suspect and pick up those lesions or at least ask for a referral because many times the symptoms might not be apparent. It could be benign lesion without any symptoms. We know that, the Gardner syndrome or colorectal cancer carcinomas, that can be kind of, it can be familial at times. And the ocular symptoms or the ocular findings sometimes can be the initial findings which can actually screen the family. That, this patient is more likely to be harboring the gene mutation, which might give rise to a colorectal carcinoma. Because we know that there are specific fundal findings now, which can be suspicious or it can be very specific for Gardner syndrome. So if those kind of things can be picked up and if we are aware of, then I'm sure the percentage is going to be a little more higher than what is reported.
Thank you.
So I think that from the point of view of a general practitioner or other physician, I think any tumor or any masses around the eye or the orbit should be referred to an ophthalmologist, should not be ignored, should not be taken lightly. And yes, lid lesions, ties, if they come, they go away, it's fine. But if they do not go away or they come back again, there's a recurrence. Again, the patient should be referred to the ophthalmologist. And then it's for ophthalmologists to decide whether there's any likelihood of malignancy or not. And all ophthalmologists need to be really very, very alert to the possibility of malignancies. And another thing to be noticed is that in ophthalmology, there are two peaks of malignancies in tumors. One is in early childhood and the other is in the older age group. So the younger people are usually kind of spared. Maybe that is the reason why it never occurs to most people that ophthalmology can also have malignancies around it. So there are two peaks early in the life and then the late life. So these are the things. Pani, would you like to add something?
Regarding the malignancy frequency, well, I think in my practice, what I've come across is only one of those odd cases of retinoblastoma. And now with private practice, definitely these cases are lesser, though I've had the experience of actually having a one-day-old infant who is presenting with a bilateral retinoblastoma, which was very rare. And I feel the younger the age at which they present, the more severe is the presentation of the malignancy. Rhabdomyosarcoma, I think I've only seen 2 cases. GNEC, we've seen 2 cases, but not many. Retinoblastoma, the classical microcalcifications, which we used to catch on the X-ray or the CT used to be our point. And until a long time, it was only enucleation, which was considered the treatment line. And we didn't give the patient a chance. But now with more modalities, brachytherapy and all, it has become much better. We are able to save the eye.
Yeah, and another thing which Sima very beautifully brought out in her presentation was now the new diagnostic modalities, that the chorionic villus biopsy, which they used in a patient to diagnose the presence of the mutation before the child was born. And then they induced, say, preterm labor at 37 weeks. And then screening the child and finding that newborn infant, which actually premature newborn infant also had the retinoblastoma, which was actually amazing, sad in a way, but amazing in the other way. So ophthalmology and the diagnosis have actually improved a lot. So I think these things we should be all aware of. And the use of brachytherapy and the intravitreal chemotherapy and now the intraarterial chemotherapy. These are all the advances that we should all be aware of, that they're there, so that we can use it in a required patient. Nidhi wants to say something.
Yeah. So as Sima brought out, even an outreach worker who's been trained to pick up the red reflex is a very big workforce which is readily available. And I think just like, everywhere abroad, they have a hearing screening and an ocular screening at birth. If we can be the force to start very simple screening, this would go a long way to pick out those early cases where you can save vision. And whenever we think of this story that, somebody who's not a doctor, somebody who's just been told, shine the torch and see if it is red, can pick up something which is so sinister, it's not very difficult to include this in universal screening programs.
Yeah, that also reminds me of another thing, that when we were, students, and or we were doing a PG and all, the internists, the SR in the medicine, the consultants in medicine, they used to carry an ophthalmoscope with them. That trend has gone. People are not even carrying stethoscope nowadays. So, which is a sad trend, but I think that it's worthwhile, that all the internists, pediatricians, they should also carry an ophthalmoscope with them and should know basic fundus examination. Like an ophthalmologist should know basic auscultation. So, internists should know a basic ophthalmic examination. The diabetologist should know the fundus examination also. And we should not give up those skills.
That I'd like to.
Yeah. Yes, Saurbhi.
Yeah, just to that only I'd like to add, this was a recent experience. So a lot of, a general good ophthalmology examination after a certain age, and every time a patient is coming to an ophthalmologist, a fundus examination, some of the other things that can help. I mean, there was this 40-odd-year-old woman who came with a simple presbyopic complaint. But very characteristically, it was one eye that was more affected, according to her. So just dilated the fundus and there was a retinal mass there. And then on further probing, she revealed a history of a breast cancer for which she had been treated a couple of years back and was in complete remission. So, mostly the trend is to go to an optical shop, get the glasses. So small things like a detailed checkup, just a fundus examination can, I think, pick up some of these rare entities that we intend to miss otherwise.
Correct. That's very, very important. So I think there's a message for maybe all the other specialties also, that an ophthalmology examination can actually go a long way in picking up systemic complications spreads much early, and which should not be ignored just because there's a rush to operate on the patient. So that thing, ophthalmic examination should be part of the full workup of, say, any oncology case, and in neurology case, and in neurosurgery case. It should not be ignored. So that's great, and so that brings us to
Dr. Sanjay. During our senior residency, we used to carry ophthalmoscope and used to detect many papillomas, and could be tumor or something in the brain. But now, of course, we don't carry all those things which we used to do previously during our residency period.
True, sir. So I think that brings us to the end of the session on ophthalmology, and I'd like to maybe end it with a very nice anecdote, that people would not know that Nidhi initially wanted to do ophthalmology. She was very keen on ophthalmology. She had a distinction in ophthalmology in her final exam, and she was very, very keen. And I was kind of saying, why? I mean, don't do that, no? But we had kind of, had an agreement that if she becomes an ophthalmologist, then we'll divide her specialties. I'll become the dextro ophthalmologist for the right eye, and she'll become the levo ophthalmologist for the left eye. So, but fortunately,
I would have got more. But going by your theory, I would have got more work than you.
Yes. So in the hindsight, it worked very well. I got to see both the eyes. And by the time she went for counseling, ophthalmology was already taken up. So I was very, very happy. And she was.
Sanjay, can I speak?
Sure, sir. Sanjay, sir.
First, to compliment you on your lecture, although it is a little because being from another speciality, सब चीजें तो समझ नहीं आती हैं. But another practical thing which I will tell you, what is happening in the government hospitals, where the training is taking place.
Right.
जो आपने अभी सर ने बोला, we used to carry an ophthalmoscope. अब तो I don't see an ophthalmoscope even with a medical specialist, and or even a professor of medicine or whatever you may say. So ultimately, there is a movement towards super specialization. हाँ, आँख में कोई प्रॉब्लम रख लिया, refer to eye. So अगर आपको इवन हार्ट में इवन ब्लड प्रेशर इंक्रीजेस एंड आपको लगा हाई ब्लड प्रेशर अगर मेडिसिन में, तो रेफर टू कार्डियोलॉजी, एंड पेशेंट भी डिमांड करता है। सो देयर इज अ वर्ल्ड विच इज शिफ्टिंग। में हर बार जब मैं हमारी ऐसी जगह पे कई बार कंट्रोल रूम ड्यूटीज लगती हैं इमरजेंसी में, जो आपने बोला मेडिसिन में रिवाज खत्म होते जा रहा है स्टेथोस्कोप रखने का। So there is a change and the change is coming in from the medical colleges. The medical colleges are developing super specialty blocks, and ultimately it becomes easier to refer to a super specialty guy and decrease your workload. Net result is कि जो आप बोल रहे हो training a doctor with the bigger skill network, और इंडिया में especially another problem is we have too many patients probably, और उसकी वजह से इंडिविजुअल डॉक्टर्स की जो ट्रेनिंग होनी चाहिए probably it is lacking. I don't think so PG of medicine going through his MD exam will be able to do whatever you require to him to do as a eye specialist, because वो probably अब ट्रेनिंग ही नहीं है।
Right sir.
So there is a change. हार्ट में प्रॉब्लम है, इको के लिए भेज दो। इवन मतलब ऐसी छोटी छोटी चीजें वी आर वॉचिंग। तो देयर इज अ ट्रेंड, मेडिसिन नीड्स टू बी रीओरिएंटेड। बट जो आपने जैसे लेक्चर लिया उससे है कि एक्सपोजर बढ़ता है, विजन बढ़ी हम लोगों की दूसरे स्पेशलिटी की। ओनली थिंग इज व्हाट आई वाज टेलिंग निधि, अभी थोड़ा सा लोग क्या हो गया है कि you're looking more towards physical meeting. I was telling her even in CSI, other forums, similar kind of stories are happening. But आपकी preparation इतनी अच्छी थी lecture की कि I wish more people would have had the opportunity to listen to this. और वैसे भी बहुत अच्छा ear and eye combo तो वैसे ही बहुत अच्छा है निधि और आपका तो।
Sir, we will put this on the YouTube channel of the branch, and then we can have more people look at it. The central point is, जैसे हमारे को हमारे डॉक्टर मनशर्मानी कहा करते थे, what the mind doesn't know, the eye will not see. So अगर if you just bring it into the realm of awareness, then perhaps somebody will think of shining a torch in the eye, if not an ophthalmoscope.
हाँ exactly. अब यही निधि क्या हो गया मेडिकल कॉलेजेस में जो हम देख रहे हैं ना, there is actually a sea change. Each specialty probably has become so big. मेरे समय में pediatrics आ गई थी, मेरे से सीनियर वाले तो मेडिसिन में pediatrics पढ़ते थे। So हर जैसे आपकी आई में या ईयर में इतनी सुपर स्पेशलिटीज बन गई हैं। So because of this, probably the training at the MBBS level and maybe even at the post graduation level is actually going a sea change. अब बच्चे इंटर्नशिप करके ही सीधा घुस गए मान लो आई में या मेडिसिन में, उसको तो एक्सपोजर हुआ ही नहीं ना कुछ भी। I have seen people, I have seen students who don't even know an ORS. Skin, I came across a resident from one of the good colleges who was working in the skin department after getting a PG, और उसको ये नहीं पता था कि उसको कोई प्रॉब्लम आ रही थी। I asked him to do this, what is this ORS? उसको ये नहीं पता ORS क्या होता है। एग्जाम के लिए पढ़ लिया, MCQ पास हो गया, जो भी हुआ, but she doesn't know in practice know what is ORS. So that is a kind of problem. Ophthalmoscope तो शायद बहुत दूर की बात हो गई है, ये चेंज आ गया है। हाँ, ophthalmoscope भी रेफर टू वो बुला लो, you send a call ना in medicine department, a call to ophthalmology department, चाहे ophthalmology का JR है, पर ophthalmology का बंदा है जो देख गया, चाहे वो JR से कुछ आता भी ना हो। So that is a problem which we are facing. मैं जो आपको एक review दे रहा हूँ medical college side से. So maybe somewhere down the line, Sanjay, what the thing is, I think the people who are teaching medicine in medical colleges need to be more aware from the eye side. What are the requirements in the teaching side from the general, from the medical side or other specialties besides eye? That is what.
Dr. Sood, we'll have a session on this. We'll have a session on this.
We should have a session.
Very rightly said that this move towards specialties and super specialty actually is affecting the training also. And though the world is moving towards that and we have to move towards that, but in the Indian scenario, in the Indian context, still there's a need for people who do much broader scope of work, especially in the rural areas, in the tier 2, the tier 3 cities now. In Delhi, of course, we can afford to have a specialist, but I think in smaller places, our scopes need to be broader. And in ophthalmology, the specialty business is much worse. For every little thing, there's specialty. Cornea is one specialty, glaucoma is another specialty, retina, oculoplasty, pediatrics, neuro-ophthalmology, everything has become specialty. But एक बची specialty sir.
Hair of the eye.
That is the hair of the eye. वो भी शुरू होने वाली जल्दी. Ocular trichology.
अभी संजय catch ये आ गया है. See what you are moving towards, that we should have family medicine. Unfortunately, ये बहुत साल पहले planning commission की ये plan थी, आज से 25-30 साल पहले.
जी sir.
I attended a lecture of one of the planning commission members. This was actually a process to be implemented over the next 25-30 years. But what has actually happened over the 25-30 years is totally a reverse. What was recommended 25 years ago, जो आप बात कर रहे हो, that is the strengthening of the family medicine component.
Right.
ठीक है ना? Where you go for a bigger, पर उसमें पैसा नहीं होता, कोई सीट नहीं उठाने को तैयार पीजी में इस समय. जब ना तो कोई पीजी में सीट उठाएगा, ना कोई इंटरेस्ट ले रहा है. So how you are going to develop that specialty is $1 million question.
So we need to empower them. We need to
हाँ,
actually
पर वो
make it
बहुत बार try किया, बहुत लोगों ने try
viable.
किया.
It has to
Even
become financially
DNB
viable, sir.
संजय, आपकी information के लिए DNB has tried this because one of my close friends, he was the head of the DNB. He was a very close friend. और उसने बहुत discuss किया. He tried his best to get this through. अगर DNB में कुछ family medicine का शायद अब शुरू किया गया है. अब वो तो change हो गया. Now another person is the DNB in charge. And he was a good, very good close friend. And some of the states even have resistance to so many of the things. चाहे वहाँ के specialists हैं, चाहे वहाँ के DGs हैं. So there is a complicated problem, whether we like it or not. Somehow the family medicine is not moving forward. What we require for a country.
Okay, so with that note, I'll hand over the mic to Nidhi for the final remarks and closing of the meeting.
I think I would defer to our mentor and patron, Dr. Rajiv Garg, to propose the vote of thanks. I especially have to thank both of you, Sima and Saurbhi, for an extremely engaging session. Of course, I had a selfish interest because I am an ENT, और एक तरफ से मैं घुस रही हूँ into the eye. But jokes apart, I feel like stories like the one that you brought out, Sima, are very illustrative, and they allow us to improve outcomes in a way that is very difficult to quantify just as one case, because this one case sets the trend for many others. Thank you so much. Over to you, Dr. Garg, for the vote of thanks.
Thank you, Dr. Nidhi. I thank Dr. Sima Das, Dr. Saurbhi, Dr. Sanjay Dhawan, and Dr. Dipali for actively participating in this ocular cancer debate. I thank all the participants who have actively joined the program. I would like to request Dr. Sima to write a summary of what she has talked about. We will like to print it in our bulletin of IMA New Delhi branch, and I will request them to join us on 5th of June on World Environment Day, where we would like to honor you with a small memento. Thank you.
Thank you very much, sir.
I'll be reminding both of you before that, so just mark it in your calendar, please.
Thanks a lot, Dr. Nidhi, Dr. Dhawan.
Thank you.
Thank you so much for this opportunity. And I hope that, as Dr. Nidhi said, at least we should start shining the torch in the eye.
Yes. Yes. Thank you. Thank you so much for this session.
Thanks a lot, Saurbhi. Nice to see you.
Thank you.
Thank you, everyone. Thanks a lot. So I'll be closing the meeting and the recording is in. Thank you. Bye-bye.
Thank you. Bye.
Thank you. Thank you.